Hello, everyone, and good afternoon. My name is Dwayne, and I am one of the global molecular specialists working within Randox Laboratories. Welcome to all of our listeners, and thank you so much for joining us today to participate in an important educational webinar relating to laboratory preparedness for the Mpox virus. We know only too well the crucial importance of quality control and clinical assurance within the molecular virology laboratory, and this session will aim to build upon that knowledge with a specific focus on Mpox. Since the initial global Mpox outbreak in May 2022, a wide and diverse range of in-house and lab-developed tests for Mpox have been developed, including cartridge-based point-of-care analyzers, such as the Bosch V-Validic. Randox is currently supplying this intuitive molecular platform across various international markets. For more information on the Bosch V-Validic and how Randox can help service laboratories in the detection of Mpox, please contact your local Randox representative for more information. This afternoon, it is a pleasure to introduce our guest speaker today, Dr. Elaine McCulloch. Dr. McCulloch initially gained her PhD at the Glasgow Caledonian University and then worked as a postdoctoral research associate at the Royal Hospital for Sick Children in the city. After a variety of roles working on assay development for various pathogens in high-risk patients, such as those with immunodeficiencies and chronic lung disease, including cystic fibrosis and COPD, she joined QCMD as a senior scientist in April 2013. Dr. McCulloch currently works with QCMD as the Senior Technical Business Manager, leading the design and development of external quality assessment schemes to support the needs of clinical laboratories. We are very happy to answer any questions that you may have during the presentation. I would encourage all audience members, if they do have a question, to please write their question in the group chat box provided, and we will answer, if we have time, any questions at the end of this presentation. So without further ado, it's over to you, Dr. McCulloch, and we look forward to listening to your presentation.
Thank you, Dwayne, for that introduction. Yes, as Dwayne said, my name is Elaine. I work for QCMD, and for this presentation, I'm going to give an overview of our Mpox EQA that we initially initiated in 2022 to help support laboratories with their quality requirements. So, if I can get my slides to work. There we go. So in an ideal world, when you go to introduce a new test into your laboratory, you'll have time to plan, prepare, you'll be able to look out into the world at what assays are available, there'll be plenty of literature, you'll be able to access lots of material, you can schedule this, it will all be nice and calm as you bring these new tests into your laboratory to meet whatever new clinical needs that you have. This might be that you are taking a traditional test and moving it on to a more molecular diagnostics, but you will be able to decide with your team how you bring this on board. When it comes to new pathogens, unfortunately, as much crystal ball gazing as you can do, you are never really going to know what is round the corner and what is going to come to you next. So you need to ensure that your lab is ready to react to whatever the next new thing or new pathogen to you that you're going to have to see and deal with. Now, there are many reasons why new pathogens emerge or existing pathogens re-emerge, and this can in part be due to microbial adaptation. It can be genetic changes that allows these things to spread more easily or become more virulent. We can have ecological changes, climate change, changes in host or vector habitats. And we've seen this in recent years where as the temperatures have increased, pathogens which we would have normally seen in more tropical climates are moving further and further north. And this goes hand in hand with the vectors for these pathogens also being able to survive, breed and spread further north, making these pathogens accessible to new regions. We also have to think about susceptibility to infection. The human host changes. What we have been exposed to in the past can impact what we are going to be exposed to in the future. Previous immunity to one pathogen may protect from a future pathogen, but as that immunity wanes, that again creates a new susceptible group that can be infected. We have global travel and trade. You can get from one side of the world to the other in a matter of hours. We have vast trade routes across the globe. And again, as travel and trade continue, pathogens can move with it. Also, worryingly, breakdowns in public health measures can have a significant impact of emerging and re-emerging pathogens. Natural disasters, of course, can break down the accessibility to healthcare. And unfortunately, as we've seen in sort of recent times, war and conflict can also have this impact on public health, access to healthcare. And when we are dealing with emergencies and the here and now, things like routine vaccinations become secondary, and there can be gaps in these protocols, and that can mean that there can be larger populations that become more susceptible to disease. So if we look back at the sort of last 20 years of these kind of emerging infections and the impacts they have, now I'm not sure how well this covers, it's quite a busy slide, but in the blue you can see some examples of new pathogens and new emerging diseases. And in red are pathogens that are new to different areas. So these are pathogens that have moved from their traditional endemic areas into new regions and become problematic or new things that have to be tested for in those regions. Now, some of these have caused problems to a greater or lesser extent, and you'll see some very well recognisable names amongst this list. An example of a pathogen that has moved regions would be Zika virus. So 10 years ago, Zika virus moved out of its sort of endemic region in Africa and it moved into Brazil, where it found a naive population that it was able to infect and spread and cause significant impact in that region. And obviously then, with global travel, that then became a problem in other regions of the world. So as we move on to looking at monkeypox, or Mpox, I should say, now. So prior to 2022, Mpox was primarily found in two regions of Africa. So you had Western Africa, where you primarily found clade 2, and you had Central Africa, where you primarily found clade 1. These were quite geographically distinct. There was outbreaks and spread within these regions, but it was localised to this area. Now, one of the things with Mpox is that its diagnostics for pox viruses actually was quite niche, and that's partly due to its sort of scary cousin, which was smallpox, which, as everybody knows, was declared as eradicated in 1980. Now, alongside this eradication programme, there was widespread vaccination, and this widespread vaccination had an effect in general orthopox epidemiology. And this was because there was quite effective, as we know, as that's how the vaccine was developed, cross-reactive immunity to other orthopox viruses. And because of this reactivity, there was protection against these other viruses, and they didn't have the opportunities to spread so much. But we are now, 40 plus years since smallpox was eradicated, significantly longer since mass vaccination has ceased. So this immunity is waning. The population no longer has this cross immunity to orthopox viruses, and these orthopox viruses are on the rise. Because of this sort of cross protection in this limited areas in which these viruses were appearing, it became a very specialist test, and diagnostics were really limited to very specialist centres, reference laboratories and the like. And most of the tests that were being used were developed in-house. There was really a lack of commercial interest in developing tests back then, because if you're only going to be targeting a few reference laboratories, there really isn't an interest in developing tests. And also a key factor here was access to material. It was difficult, so people weren't inclined to develop tests for these viruses, as you simply couldn't get your hands on material. But we hit 2022 and Mpox was on the move. And in May 2022, there were clusters of Mpox identified both in the UK and Portugal. And in the UK, the initial case was a gentleman who had travelled from Nigeria, which would, was not, it's not something unusual. But then it was associated with a cluster where the other people did not have any history of travel, and this was now becoming linked to patient spread. And we started to see pockets of Mpox appearing in other regions. And by the time we got to the 23rd of July 2022, the WHO had declared the outbreak a public health emergency of international concern. So I've just got a map here of Mpox spread. This is actually over the last couple of years, but the pattern was very similar in the first sort of 6 to 9 months of the outbreak. And as you can see, it got everywhere. Lots of countries were impacted and started to detect cases of Mpox. One of the things from a clinical need was that it was being underdiagnosed early on. There was a lack of recognition of the disease. A lot of the patients that were affected with the clade 2 outbreak strain had less lesions than you would normally see traditionally. And also, Mpox was never really associated with being a venereal disease, but the sort of sexual transmission sort of changed the type of people and specimens that were being tested. So unfortunately, early on, the lack of diagnostics, and this is the case for anything new that comes out, if there's a lack of diagnostics and disease recognition, this can lead to uncontrolled transmission. So really, from this point, there was a requirement to expand testing, get testing outside of these special laboratories into routine diagnostics. And in order to do this, good quality support is required to make sure that when these tests move from these specialist areas to the wider community, they are good to test and they're going to provide the results that are needed by the laboratories. So around this time, QCMD were being contacted by laboratories as they were starting to set up new assays, looking for support. We identified that there was this need to have a pilot EQA to support these laboratories as this outbreak progressed so that these tests could be developed. Now, in May of 2022, just as these outbreaks were beginning, we'd identified this requirement for the support because of this need for expanded testing capabilities. Now, QCMD has many, many years of EQA expertise. We know what we're doing when we're running EQAs, and we know what we're doing when we're providing the materials to laboratories, but we are by no means experts in all the pathogens that we deal with. So we really needed to partner with an expert laboratory or organisation who would be able to support this programme. We needed somebody who had access to the isolates, and we also needed somebody who had access to be able to prepare material and prepare safe material that could then be used within an EQA. And we were very lucky to be able to join with a collaboration of IMB in Munich in Germany, who were able to support this project. So just to give you an idea of the timescale we're talking about here, was, as I say, the first cases of Mpox were started to be reported in May. By June, we had agreed on a collaboration between ourselves and IMB. We were looking at the panel design and how the EQA was going to be run. By the time we had got to August, we were confident that we had everything in place, production of the viral stocks, and one of the most important things, safe viral stocks. So we had identified a mechanism to inactivate the material so that it could be safely transported to all participating laboratories. So by August, we were confident that we could run a pilot EQA scheme. We announced the scheme to our participants, opened up registrations and allowed laboratories to register for the scheme. Throughout September, we did extensive characterisation of the material that was going to be used. This was done both here in Glasgow and also in Munich, so that we could prepare top quality material to go into the EQA scheme for the laboratories. And by October, those samples were being distributed to participants. So as you can see, over a very short period of time, we were able to recognise, generate and develop an EQA pilot scheme for laboratories to use. Now, looking at the panel design, most of you will probably be familiar with QCMD, but for those of you that are not, QCMD generally has panels that have two types of samples. We have core samples, which from a regulatory point of view, we will expect laboratories to detect. Then we also add educational samples that can be challenging samples or provide additional information to laboratories, but we would not necessarily expect laboratories to detect from a regulatory point of view. We feel that providing both a regulatory and educational component to our EQA schemes is of benefit to the laboratory because it can help drive and improve the quality they require. So as I said earlier, there are two different clades of Mpox, and we wanted to include both of these within the EQA panel. We included a true negative sample, so this was a sample purely containing a transport medium with no pathogen added. And importantly for this scheme, we had two educational samples of closely related orthopox viruses, one of which was cowpox and the other was vaccinia. So for the 2022-2023 distributions, we had 4 in total. We had 2 in October, followed by 1 in March 23 and 1 in May. The reason that we had 2 distributions so close together in October 2022 was down to demand. We had planned to support 100 laboratories with our first round, thinking that, that would be, a reasonable number of laboratories, but it soon became apparent that there was significant interest and we didn't want to disappoint anybody, so we ended up running 2 schemes pretty much back to back. And this was so that we could incorporate and support as many laboratories as possible. We also didn't want to delay the distribution of the EQA scheme for those that had registered early with us. So that's why we made the decision for all those that were registered early, they would get their panels, and then we would have a follow-up scheme for any newer laboratories that registered. And as you can see, we had 86 laboratories registered for the first two distributions, 82 for the one in March, and it sort of tailed off a little bit by the time we got to May 2023. And by this point, the peak of the outbreak was starting to tail a little bit, but that subsequently changed again. So from these 4 challenges, you can see that we managed to distribute to a number of different countries. The majority of laboratories did return results to us. QCMD actually allows laboratories to return multiple data sets to us if they wish. So we actually had more data sets than laboratories. One of the key questions that we asked as part of the study was for them to tell us whether their assay they were using was specific for Mpox. There is a lot of generic orthopox virus assays out there, so we thought it was important to be able to identify those laboratories that were able to specifically detect and differentiate Mpox from other orthopox viruses. We assessed whether they were using commercial or an in-house developed assay. And although this programme was run as a qualitative programme, QCMD always allows laboratories to return quantitative data if they have it. And in this case, we had a handful of laboratories that returned quantitative data. Looking at our global distribution for the 4 schemes that we have run, we covered 5 geographical regions of Europe, Africa, the Americas, Southeast Asia, and Western Pacific. We had a total of 37 different countries and a total of 192 different laboratories. So if we look at the results that we received over the period, we had 318 registered participants and 299 submitted data, which is a 94% feedback rate. Now, this is quite positive for a new pilot scheme, as we often find that there is some laboratories that simply don't return results to us. Some laboratories sign up for the scheme, but then ultimately decide they're not going to implement the assay. So we were quite pleased with this level of feedback. In total, we had 346 data sets submitted, and of those, despite the number of commercial assays being available, 52% of those data sets were generated using a commercial assay, and 48% were generated using an in-house developed test. And 67% of the overall assays used were reported to us as being specific for Mpox. So if we look at the results in a little bit more detail, as I said, the first 2 challenges that we distributed were repeat challenges just to get as many participants as we could enrolled in the first instance. And if we look at the core samples for these programs, we can see that there is really nice performance, and well over 90% of the laboratories are able to detect the Mpox samples included within the panel. And even if we look at the low concentration educational Mpox sample, this still is over 90% of participants are able to detect this. One area of concern, however, was the true negative sample. In the second challenge, it was only 91% of laboratories that were correct with this, which is significantly lower than we would normally expect to see in a standard EQA scheme. We normally only expect to see 1 to 2% of false positivity in a negative sample. Now, we can only speculate as to why this may be. It may be that laboratories weren't familiar with the test and maybe not running tests quite as they should be, following all their control mechanisms. It could be that they were they were dealing with a lot of samples at high viral load and had contamination issues. But it was obvious to us that this was an area that we needed to have a look at and keep an eye on. When we moved into the first challenge of 2023, we changed the design slightly, made it a little bit more challenging, lowered the concentrations of the virus within the panel. But as you can see from the core samples that we included, we still had a very good level of performance. And again, for the second challenge in 2023, very good level of performance. And for the 2023 challenge, we've seen a return to what we would expect for that true negative sample up at 98%. So hopefully that initial teething problems with people unable to correctly identify the negative sample was something that was inherent to their initial setup, and people learned from the EQA to improve their assays accordingly. One of the areas that we delved into in a little bit more detail was the extraction methodology. Now, this is something that can be sometimes forgotten, or a trap that people can fall into, is that they are concerned with looking at the assay that they are going to use for the detection of a pathogen, but not how their whole workflow will fit together. So they may be looking at an assay that they can fit onto an existing platform, but they don't necessarily take into consideration the extraction method they're going to use with it, and make sure that they're suitably validating the whole workflow from extraction through to amplification. So we had a look. This is not part of our formal assessment as QCMD as EQA. We assess based on the assay that people have used to do the detection. But we thought that this would be an area that we should delve into more detail, just to see if we could to identify any trends of which extraction methods may also provide benefit to people as they were developing and validating their tests. So when we looked at the extraction methods used, we found that the commercial assays, there was a significant difference in using a commercial extraction method for testing the samples and improving the performance. And this is also true for commercially available amplification methods, which were also statistically better than those of in-house assays. So this was quite encouraging that there were commercial assays available to laboratories that they could use and they would perform well. One of the other areas that we wanted to look more closely into was the specificity of the tests. So, as I said, there were some generic assays out there that were orthopox generic testing assays that weren't able to differentiate between other related viruses. And this can be important from an epidemiological point of view if you don't know what virus you have, to make sure that you're detecting for the correct virus within your assay. Now, you need to be aware of the limitations of your assay. It may be that this is okay for you. It may be that you don't need to tell the difference between monkeypox virus and other related virus, because you're only using it for a screening assay, and you will be confirming later on the actual virus that has been detected. So one of the most important things when a new assay is being brought into your laboratory is actually knowing how you're going to use it and the limitations of this assay, because it's important to know, is this assay okay for you? Now, QCMD as an EQA provider, we don't tell laboratories whether they have passed or failed their EQA. We are only providing the data and the results to support their own assessment of their assay. So it might be that being unable to differentiate between different orthopox types is okay for you, but that needs to be justified as part of your implementation of an assay. But as I say, we wanted to look a bit further at this to see if this was truly down to the fact that people were using assays that they were unable to differentiate between the different pathogen types. So when we looked at this in more detail and looked at what people had told us their assays were able to do, we noticed that a significant proportion of people had told us that their assay was Mpox specific, but they were reporting between 8 and 16% false positivity for those assays. So although they believed their assay was able to differentiate and detect Mpox specifically, this was not reflected with the results because there was a significant percentage of false positivity. There was obviously a significant proportion of people using generic assays that returned false positive results, but that was because they were unable to determine whether it was an Mpox virus or not. So this is something that laboratories, when you are looking at the assays that you are bringing in, if it says on the box that it is specific, you need to check that it definitely is specific and if it is going to be fit for the purpose you need it for. So this is an area where people would need to have a closer look at what their assay is capable of and whether it is suitable for them. So some of the conclusions here is that overall the performance of EQA participants was acceptable with correct detection of all Mpox positive core samples and true negative samples by 91% of participants over all 4 challenges. From the participants using Mpox specific workflows, up to 16.4% of data sets reported the vaccinia and cowpox vaccines as false positives. And as I say, this is something that is an area of concern that laboratories would need to look at in more detail. Because if your assay is believed to be specific and it's not, it either needs to be improved or you need to accept that you are going to suffer from this rate of false positivity. So as I say, laboratories need to be aware of the limitations of their assay they use and their impact of overall workflow. So lessons learned as part of this whole collaboration and the EQA that we have provided is that it requires close cooperation between expert institutes, industry, EQA organisations, to be able to rapidly develop schemes that will allow quality assessment checks to be put into place when there is disease outbreaks. And this is critical for patient management, tracing contacts and preventing spread. If you do not have a good quality assay, then you're not going to be able to support the control and the services needed by your clinicians. This recent outbreak of Mpox virus has firmly established its presence internationally. It's not going anywhere. So Mpox is now considered to be a new addition to the pool of circulating STIs. So this is going to lead to a demand for quality assured diagnostic capabilities in clinical laboratories. This new EQA scheme offers one of the most versatile and multi-purpose panels for orthopox viruses, and it will continue to ensure diagnostic quality in the clinical setting. And we will continue to update the panels and provide these into the future. Now, none of this is possible with, as I say, without the collaboration of our partners. So I would just like to thank my colleagues at the IMB in Munich in Germany, Rosanna, who brought a wealth of knowledge to the project, along with Joachim and Roman. The team here at QCMD, who drove the project forward and pulled the data together to be published, And as always, when publishing data, it always helps to have a team statistician, and Harry is extremely helpful in that manner. If anybody would like any further information regarding this initial study, then please feel free to have a look at the publication that has just recently been published in the Journal of Clinical Virology, where there are more details on the study and the outcomes. I'd like to thank you all for listening.